much for an excellent talk.
Okay, next in line is Neil Mott from London, who's going to present on transcatheter aortic valve implantations via the subclavian artery. And I guess you've noticed that we've changed the program somewhat so that we keep the access and practical talks in one session.
Thank you, Michael. Well, there's the title. We're going to talk about some alternative access routes for implantation. Worldwide, the transfemoral approach has been the commonest approach used for TAVI, and this is obviously an approach that is favoured by the interventional cardiology community. But there are a number of issues with femoral access for TAVI, and I think the ones that I want to focus on today are the fact that there still is a significant incidence of major vascular injury to the iliofemoral vessels. And there's also an issue of precision of control of deployment of the device. The source registry is an excellent piece of work, and I think here you see the range of major vascular complications that still occur in the transfemoral population, and that is mirrored in our own personal experience. These are the sorts of aortas and femoral vessels which some interventional cardiologists will take on for a transfemoral approach, but undoubtedly your incidence of major vascular complications will be significantly increased if you try to insert these large sheaths into these vessels. The control of deployment as well, I think you can see here, this is a transfemoral case, and you can see there's quite a lot of movement during deployment of this prosthesis. And I think all of us who have experience of what you might call near-access approaches, which Olaf has just described the transapical, and I'll go on to the transfemoral, is there's a lot more control and precision of device positioning and placement than you get from a transfemoral approach. So the subclavian artery is obviously a fairly variable structure. When we do a subclavian access, we do a direct cut down. I'm going to show a film at the end of this little presentation showing that in more detail. And the 18 French sheath is inserted down, usually across the aortic arch and into the ascending aorta. And the prosthesis is inserted nicely in the sheath. And this shows a feature. I mean, one of the key things to see here is the very close relationship between the sheath and the device, which is really why you get that enhanced control. But even the subclavian has some limitations. It can be a small vessel. Sometimes this is not very acute, but often there can be really a very acute angulation here. It can be diseased. There can be problems if you have a very dominant vertebral artery in terms of vertebral obstruction, and there are certainly concerns about intubating the subclavian with this large sheath if you have a patent mammary artery. We know that we can undertake conventional aortic valve replacement through small incisions, and this is an example of a case where we undertake direct aortic access. Again, I'll show you a video. This is a tissue forceps through a little mediastinotomy onto the ascending aorta. You can see at this stage the core valve is still actually within the tip of the sheath, and you can imagine again that you have incredible control of positioning of this device with such proximal, with such near access. You obviously have to be careful at the end of the deployment to make sure that you withdraw your sheath slightly to allow complete deployment of the device. And that's the result one hopefully gets at the end of the procedure. Just to put in context what I'm going to show you, that this is our experience at the Brompton, where we've done, in fact, 99 TAVIs now. But if you look, we've done 12 transapical and 13 subclavian or direct aortic access. So 25% of our patient population have been undertaken through what you might call alternative or near access. Our subclavian experience, we had the intention to treat 12 patients. One of these was early in our experience and really had a very small subclavian artery. We were doubtful we could intubate it, and the patient actually had a balloon valvuloplasty because we couldn't get the 18 French sheath in. Otherwise, these cases have gone very smoothly. We had one 30-day mortality. This is a patient who went home, who presented to a general hospital at 29 days with an acute abdomen and a mesenteric infarct and had a critical superior mesenteric artery stenosis. We also had one brachial plexus neuropraxia. This is, I know there's been another couple of instances of this, and I think that this was a patient where, which we filmed for the Technicollege, where we put a tape and retracted the medial and lateral pectoral nerves to improve exposure. And I think what we've done by doing that is put traction on the lower part of the brachial plexus. And the patient woke up with a very weak and numb arm, but that was recovering quite, we did some EMG studies, that was recovering quite well. So I think it's just something to bear in mind with that approach.